All right, so we've reached the half-hour mark, so let's get started. Welcome everyone to this week's installment of AMSSM's National Fellows online lecture series. My name is Haruki, one of the sports medicine physiatrists at New York University. I'll be your moderator for tonight, and this lecture series is sponsored by the AMSSM Fellows Online Education Subcommittee, co-sponsored by the Education Committee and Fellowship Committee. Tonight, we'll be discussing running medicine. And before we get into our topic for tonight, I want to remind everyone of next online fellow lecture, which will be on Jeopardy style pediatric MSK cases. This lecture is scheduled on Wednesday, June 3rd at 8:30 p.m. Eastern Time and will be given by Dr. Liu and will be moderated by Dr. Goldberg. So the goals of this National Fellow online lecture series is to serve as an adjunct to your individual fellowship program education and to provide a sports medicine fellows with direct access to learning from experienced AMSSM members and guest speakers in a variety of formats. Also, this is meant to assist in CAQ exam preparation. Housekeeping items. So please mute your devices, microphone, and turn off your video. You can submit questions at any time through the chat function, and feel free to include your name and program if you wish. At the end of the talk, I, as a moderator, will ask the questions during the Q&A based on the questions submitted. Please also complete the evaluation at the end of the lecture. One of our new efforts is to facilitate more input from our audience, and there are a couple ways to do this. So first, a web link can be found by going to amsssm.org, click the Education tab, and then select Fellow Online Lecture Series. The link is near the top of the page as seen in this screenshot. Second is by scanning this QR code. It should take you directly to the form to fill out. When filling the form out, we ask you to please keep in mind that the primary goal of this series is to assist in CAQ progression for the fellows. And now I'd like to introduce you to our expert speaker tonight for tonight's lecture, Dr. Sara Raiser. So Dr. Raiser is a sports medicine physiatrist at the University of Virginia Runners Clinic. She completed her primary care sports medicine fellowship at the Stanford University. She is currently assistant professor in the Department of Physical Medicine and Rehab, associate program director for the PM&R residency program, and then team physician for James Madison University. She served as a associate medical director for the Atlanta Track Club Elite Development Team from 2020 to 2023. She's the founder of the Running Medicine National Ground Round series and is a co-host for the podcast series Interdisciplinary Case Miles, sharing the interdisciplinary method to treating runners through a case-based approach. Her clinical and academic interests include running medicine, kinetic chain analysis, overuse injuries, the female athlete, and in medical education. So without further ado, please welcome Dr. Sara Raiser.
Thank you for the invitation and the kind introduction. So, I'm going to talk on running medicine, and this is a lot of what I do. And so, the single session is really a bird's eye view. I am going to mention a few of the topics that we have sessions already or upcoming that are specifically expanding on other topics. So, some other areas that you might look into if you're reviewing running medicine specifically. So, we'll kind of jump around to topics and then also very much kind of put together a clinical picture and how we would go about doing a visit for someone who's coming in with a running related injury. My disclosures are not directly pertinent to our conversation today. We're going to talk about running medicine. We're going to talk about running related injuries and associated risk factors, and then delineate the multifactorial etiology of these running related injuries. So, as I mentioned before, there's a lot of there are quite a few topics that we can potentially cover. So, I would be sure to review things like race medicine, exercise-associated collapse, bone stress injuries, tendinopathies, even peripartum exercise, extracorporeal shockwave therapy has a role in bone stress injuries and chronic tendinopathies in runners. And then, of course, regenerative medicine and orthobiologics play a role. Runners generally don't like to shut down, so anything that you can do to treat them without having to shut them down is certainly a big win. So consider reviewing some of these other topics as well. So when we talk about clinical running medicine, I think about a few different things. One is injury prevention that I would consider primary prevention. So someone who has not had an injury or trying to prevent injuries, which is my favorite. I love doing optimization, performance optimization, enhancement as much as we can without having to deal with the injury. But most of the time when I'm getting these athletes, we have an injury that we're dealing with. And in the midst of that injury, we're doing secondary injury prevention as well as helping to boost that injury healing by looking into these different ideas. So I talk about them as the three pillars. I talk about training errors, biomechanics, and nutrition. And this is what we're going to really delve into today. A lot of different things fall into these categories. So, talking about daily life stressors and recovery and energy balance, and a lot of the things that you're going to look at on your evaluation in the clinic. All of this is going to kind of boil down to these three main ideas. And certainly we can look at performance optimization too. I have athletes who come in and just want to take a look at their run gait and, certainly prevent injury, but then, hey, can we get more efficient and improve running economy to become a faster runner? Because that's always more fun too, right? Um, Interdisciplinary care teams are just absolutely crucial for runners and overuse injuries. I almost always work with a physical therapist and a sports dietitian if I can get that athlete there. Sports psychology is wonderful, sometimes a little bit harder to come by. Performance psychology can be helpful. And then oftentimes I am calling on my physician specialist, particularly from the endocrine side when I'm dealing with low energy availability. But sometimes we're pulling on GI, cardiology, hematology, or even gynecology, urology, even I've referred to as well when we're dealing with some of these concerns. And then don't forget your performance team and your support team. So, performance team thinking like your coach, folks who may be outside of that medical realm, who we need to potentially be careful with what we're discussing with them. And maybe we have a liaison like an athletic trainer who's communicating with them. But it's really important when we're getting someone back to return to run, for example, that we're collaborating with that person who's dictating their ongoing training. And then their support team, their parents, their friends, their peers, folks who are on the team with them. So remembering that all of this does not happen in a bubble. All these people are really important, and we have to think as the athlete as a whole. So we're going to talk about these three main ideas and go through a case as well. So when we're talking about running related injuries, we are generally talking about chronic overuse injuries. And I say most of the time because you have the runner who trips and falls, sprains their ankle. We have things that are certainly acute or other medical related concerns that we may be looking at. They may come in with fatigue, poor performance, insomnia. So there's certainly things that we may not necessarily see that are exactly in this category, but generally that's what we're dealing with. And just taking a quick peek at the literature, there are quite a few systematic reviews looking at running related injuries. This particular one that I chose, the injury incidence they found was around 40%. We've seen numbers all the way up to 80% that folks who are running getting injuries at some point. And in this study, they saw the highest incidence of joints injured was in the knee, the ankle, and the lower leg. And the highest incidence of injuries were in the anterior compartment tendinopathy is number one, which I would consider shin splints. Patellofemoral pain syndrome, super common, and Achilles tendinopathy. So you'll notice bone stress injuries aren't in these top three, but that's certainly a very large one that we're dealing with. And especially when it comes to the runner's clinic, those are folks who are getting referred specifically for that big workup as well. So, overuse injuries, we generally think about bone and tendon, but they can be other structures as well and other soft tissues. Generally, there's some kind of absence of trauma, but sometimes there's a relation to it and later insidious onset of pain. Generally focal pain, but sometimes these folks have been running through an injury for a while and then they start developing faulty biomechanical patterns that may also cause pain. And so sometimes we're peeling the onion layer to figure out where the actual problem is. And impaired performance is oftentimes what brings folks in. So sometimes people are running with pain. We have an argument about what a running related injury is. Is it something that keeps someone out of running, that makes them modify running, or just that they have pain when they're running? And so impaired performance means that pain's finally gotten to the point that either they're worried about it or it's painful enough that they're having a hard time running or competing. Anytime that we work out, we are having some level of microtrauma. So that's bones and soft tissues. We get local tissue damage, and that's how we get stronger. So we have the recovery that happens behind that. If there's a mismatch and we've got more overload than recovery, then we ultimately end up having pain or dysfunction. And that's what brings athletes into the office to figure out what's going on and how do we get them back to doing what they want to do. So, why do overuse injuries matter? Well, number one, we've already talked about poor performance and keeping folks out of doing the things that they love. Up to 80% of runners may experience running related injuries, and that is a quite a large number. Most of this lost training or competition time is due to overuse injuries, and unfortunately, they have high recurrence rates. Oftentimes, this could be attributed to the fact that if we bring someone in and rest them and then send them back out into the environment where their injury occurred previously, they may simply go back to their same habits and develop that same injury all over again. Pain and dysfunction can persist. So I always caution folks running through pain that we're really kicking the can down the road, and we may end up taking an acute pain that turns into chronic pain that can be a lot tougher to manage. And we need to treat the underlying cause. So ultimately, the crux of this whole talk is figuring out what is the underlying cause that we need to address to make sure these injuries don't happen again and these folks go on to enjoy their quality of life. So, several systematic reviews recently looking into running related injuries. The biggest thing they had in common is they noted there was a lack of high quality studies that they're evaluating risk factors. So, we really don't have a great way to pin down what exactly is going on. We have a little bit of evidence behind some risk factors. We certainly are going to talk about some kinetic chain, biomechanical concerns, anatomical concerns, but also things like someone who's a novice runner is going to be at higher risk for injury, someone who's running more than 20 miles a week, someone who's experiencing problematic low energy availability. So that's our triad, or REDS. They may have had a prior injury. That's one of the biggest predictors of having another one is having had a prior injury. Their mechanics. And then a recent study came out that was quite interesting, was looking at a single excessive running session. So one that was 10% longer than any run that this person had done in the last 30 days, set them up for a higher risk. And I've certainly seen scenarios like that have come into the office from an anecdotal perspective. And then there's some things that are protective. So there have been some studies looking at things like parallel shoe use, being able to alternate shoes that has been helpful in terms of preventing injury. So ultimately, we know that running related injuries are multifactorial. There's no perfect formula or solution. And this means we have to talk to patients. And sometimes this is a lot of touch points. This is multiple providers who are seeing patients and getting an opinion. And then the patient also kind of working through all these things as well. So this takes time and quite a lot of counseling and talking and sometimes troubleshooting. And occasionally we go back to the drawing board with recurrent injuries when we don't find the right puzzle piece. So overuse injuries are ultimately a puzzle. I think this is part of why I really enjoy working with these athletes because there's so many different things that we need to look into, and sometimes we don't ask the right question, or the athlete isn't connecting the right two things that are bringing the injuries on to begin with. Sometimes I get the puzzle piece from one of my partners. Oftentimes, that's a dietitian who gets some important information that makes a really big difference in terms of how we approach a case and do the education and counseling with the patient as well. So, my partners in crime with us are really important. There is a paper called Evaluation of the Injured Runner. I recommend going through it. Dr. Wilder and Dr. Magram put this together, and they go through these theories for overuse injuries and kinetic chain evaluation that I always bring up anytime I talk about running and overuse injuries. The principle of transition is the idea that something changed at some point that the body didn't adapt to fast enough. And that's what ultimately leads you down this train that develops a bone stress injury. So this could be 3 days ago, this could be 3 months ago, 6 months, a year. And so this is one of the things that we're trying to figure out when we're talking to the patient that may have potentially started us down this path of having an overuse injury. And then this idea of victim and culprit. So I classically like to talk about patellofemoral pain syndrome. So the patient comes in with anterior knee pain and they think the issue is the knee. Well, the victim is the knee, and that's where the pain is, but ultimately the culprit's typically up at the hip. So it's more the neuromuscular control, the strength, and the mechanics that are happening up at the hip as opposed to the knee specifically. So we want to find the culprit that we need to address, but then we may also need to address pain in the knee, for example. So maybe we're using anti-inflammatories or things to reduce pain, but then addressing culprit. And if we don't address the culprit and just address the victim, we're going to end up having recurrent injuries. So I like to think about this perfect storm, again, putting these quote unquote three pillars together. So nutrition, training, and biomechanics. And this is the path that we go down to figure out what's going on from the athlete's perspective. And then I like to overlay medical because we can't forget about this part, right? So if someone's got allergies to certain food groups, they're lactose intolerant, they have a malabsorptive issue, we really have to consider those things as well because that's a big component of what's going on. We can't forget to ask those general questions too. So, thinking about this case, a 19-year-old collegiate distance runner in their third year of college, and they interestingly actually presented with proximal lateral leg pain and ultimately were diagnosed with a high grade posterior tibial stress fracture in that proximal tibia. So when this athlete comes into the office, I've got a lot on the agenda. And so I'm going to go through history, physical exam, and then workup. And it's going to look a little different for everyone. But I'm going to hone in first on history. And ultimately, when I'm asking all these questions, some of these questions may come at a later time, especially if they're more sensitive, if there's some issues I'm worried about from a nutrition standpoint. If I lose rapport and this patient stops trusting me, they may not potentially come back for that next visit. So I want to be sure that we're gradually building to some of the more challenging questions. And then I also preface some of these things. So when I'm asking some of the sexual health and menstrual questions, especially for our younger athletes, I'm going to let them know that we're looking at these things because we're concerned about bone health and looking at their overall nutrition. And we want to ask about things like life stressors. So, what's their job like? Have they had major transitions? Do they have kids that they're running around after? Are they sleeping? What's their mental health like? Have they had prior injuries? Asking some questions about their hormones. So, looking into problematic low energy availability, but also something that could be more organic that's impacting it as well. And then illness and signs of overtraining. These are important as well. Sometimes athletes come in and they have an injury because they had the flu several weeks ago and they were just pushing to come back too quickly. So we can't forget that athletes are human too. And so asking all these different components and then certainly a full past medical history. And then physical exam is going to be a focused exam. So they come in with knee pain. We're looking at their knee, but then we're also doing a really comprehensive kinetic chain evaluation. And you can get through a lot of these things pretty quick once you have a method to the madness. Getting someone up from the chair, I can look at four or five different things, just having them stand up, touch their toes, do a couple functional exercises before they even get on the table. And oftentimes that informs some of my exam on the table as well. So even looking at static posture, so looking at folks standing and what their hips and back look like. Also looking at what all those things look like when they're laying on the table, when they're seated. So all those different postural positions. Looking at passive things like range of motion, but then also making sure that we're looking at strength, not only just testing, do they have full strength and can fully resist us, but do they have strength in the planes that they need it for their activity? So running specifically in single leg stance is a big one to look at as well. When we can get them on the treadmill and look at their run gait, that is ideal. But oftentimes, number one, it's not plausible in terms of time at their first visit, and they may be injured at their first visit. So we want them to be healthy when we get them on the treadmill. And having a treadmill in the office can certainly be a big plus as well to take a peek at that. And then looking at workup, this is going to vary widely depending on what's going on, but could include imaging, compartment testing, looking at their nerve function, potentially labs, and then an array of referrals as appropriate. So if we start in on nutrition, one of the things that I get quite a lot with these runners is starting to talk about potentially referring to sports dietitian and then talking about some of the nuances we want to look for. And I get but I eat healthy. And I had that just today at one of my last patients this morning. I've really started to try to explain, well, you can't eat healthy. You may be eating some of the right foods, but the question is, are we getting the right timing? Are we spending periods of time during the day in a catabolic state so that we're breaking into our reserves and stores, and so we're having to get out of that deficit frequently. Are they feeling nauseated in the morning, so they're not eating breakfast? And sometimes that's our whole goal. The first time I see them is I want to see you next and make sure your shin doesn't hurt, but I also want to make sure you're eating breakfast on a daily basis, so I can give them some short goals even before we can get them in with a dietitian. If they have restrictions, allergies, they're vegetarian, certain foods that they avoid, that can also send me down a path to be able to either get some lab work to look for some micronutrient deficits, but then also to give them some guidance. I never tell folks that they absolutely have to change the foods that they're eating and the restrictions, but it informs me in terms of how can I better help these folks and also have a better idea of why they may have had their injury. body dysmorphia, and I put eating disorders, disordered eating, and body dysmorphia all in here because we cannot forget about the mental component with all of this. Sometimes we've got psychiatric illnesses that are here as well, but we cannot forget culture and the way folks grew up in their home, where they're transitioned to if they're in college in their first year of college, coming out of having family that's making food for them every day, and now they're having to go out and get food. So even thinking about the nuances that may be changing in their life and some of the cultural pressures that may be happening. Sometimes if we're trying to get an athlete to gain weight, which I'm oftentimes pulling on my endocrinology partners and maybe primary doc to help with those types of things, we may need mental health support with that too, and someone acclimating to their body and being able to ask questions as they're going through this process. So talking about low energy availability, that's a big component of all this. And I have this conversation with just about every athlete that I see because it sneaks up on us in so many ways. If we see someone who's underweight and has a very low BMI, sure, there's concerns there. But even my athletes who are normal weight or potentially in the overweight category, they may also be experiencing periods of low energy deficits. And I've had several patients recently having that experience that really made big gains once we could address those from the nutrition standpoint. So, energy availability is what's left over to supply essential body functions after activity energy expenditures. So, the body doesn't get to decide how much activity you do that day and how much is left over. It's basically got to make do with essential functions, with whatever is left at the end of the day. So, that energy availability is calculated by energy intake minus the energy cost of exercise relative to fat-free mass. We have generally thought of the idea of a healthy adult being around about 45, and this critical threshold that starts putting us into deficits and seeing deleterious effects on the reproductive cycle and bone health at around 30. But this isn't absolutely perfect, and everyone's a little different. And there are a lot of challenges in calculating someone's resting metabolic rate and what someone really needs in terms of their nutrition, and that changes on a day-to-day basis. So all of this ultimately ends up being somewhat of an art. We've got to make some good estimates and then educate the patient on how to know when they need more or less energy intake and when to time all of that as well. We think the critical threshold might also be a good bit lower in male athletes, and potentially this may be suggestive of why we see this happen more in female athletes than males. However, we can't forget to ask our male athletes because this certainly does happen, especially our high volume athletes. I like to think about this particular metaphor that Dr. Dan Benardot always talks about. And so he talks about this idea of looking at your car with an empty gas tank and saying, hey, we're going to drive all the way across the country, but I'm not going to fill you up until we get there. So we liken this to the athlete who's waking up in the morning and running on zero for their workout that morning, right? So the car is not going to go anywhere, right? We can't just fill it up and guarantee we fill it up afterwards. And we have to have the same thought process with our athletes. So that morning workout's got to be fueled, and we want readily available fuel. That prevents us from diving into stores and being in deficits later. So thinking about really fueling for that activity level is important. And I think the way that you're phrasing it to your patients and helping them understand is really what's going to give you the most bang for your buck in outcomes. So low energy availability, Barbara Bridgewater started noticing athletic amenorrhea in the 1980s. We came out with the female athlete triad that was coined in the 1990s, looking at kind of the extremes of this triad, the osteoporosis, amenorrhea, eating disorder. And over time, started noticing that this can actually happen on a spectrum. And ideally, we want to try to catch this when we're on the more optimal side of the spectrum. So again, still looking at low energy availability, reproductive dysfunction, and abnormal bone health as well. Relative energy deficiency in sport was coined in 2014 by the International Olympic Committee and essentially started expanding the idea to multiple body systems, and the idea that prolonged or problematic low energy availability ultimately is affecting all these body systems. So they came up with these two models. So one looking at health outcomes, the other looking at performance outcomes. And I think these are really valuable to show to your team because your athletic trainer, for example, might look and say, oh, yeah, decreased athlete availability. Yeah, this person stopped showing up to practice on time. They oversleep. They feel crummy. So being able to have multiple folks on the team be able to identify some of these things as well. I want to make a couple of plugs for some of the sexual health questions because they're so important to ask. And then also understanding that normal menstrual cycles are not simply monthly bleeds, right? So a monthly menstrual bleed is a good start. However, it can still be anovulatory. An athlete could be on a hormonal contraceptive and tell you that they're having a monthly bleed, but really that's a withdrawal bleed and not a true menstrual cycle. You can sometimes get some ideas of changes in their reproductive health when they have changes in the characteristics of their menstrual cycle. So, the length of the bleed, how heavy it is, if they have other symptoms with it. But ultimately, we need to simply ask, was there something that changed? When did they perceive that change? And sometimes, going along with the Ledbetter's principle of transition, sometimes we see that correlate with some of the issues. Of course, changes in the menstrual cycle are going to happen at a later time. It's not our first signal that something is wrong. It means something's been wrong for a while or is really significantly wrong. Um, One of the studies, I know this is an old study, but in 2001, when they looked at numbers of distance runners with secondary amenorrhea, up to 65%. And this is not okay. And we, unfortunately, there's been some level of cultural acceptance with this as well, that if you're a elite runner running high volume, that it's normal for you to lose your menstrual cycle. But what we know is we really need folks to maintain that. And if they're not, we need to make sure that we're assisting them with support of their bone health and energy availability and balance as well to keep them healthy. Even short periods of time that that female athletes are not having their menstrual cycles or having abnormalities, low energy availability can impact their bone health, especially in adolescence and in their early 20s, because we're not reaching, potentially not reaching peak bone health, and later in life that can really make a big impact. So we cannot overlook these things, and it continues to happen today despite us understanding some of these concepts a whole lot better. And I will oftentimes bring my gynecology partners on in some of these cases, especially if menstrual cycles are significantly abnormal, and we're not correcting this by addressing low energy availability. Endocrinology, I will also oftentimes get on board, especially if cycles have stopped and we're getting to that 3 month mark, because we want to make sure that we are potentially starting therapies to help protect bone health if we haven't been successful in getting menstrual cycles to restart by addressing nutrition. Males, we need to ask these questions too. So, looking at for low testosterone, um, we know this is understudied in males, but we need to ask things like, do they have decreased libido? If you're early morning erections, do they have things like fatigue, poor mood, other signs that could be suggestive of prolonged or problematic low energy availability? And then ferritin is a big topic in our runners. So ferritin we think about as our total iron stores. Sometimes we'll get it in isolation, but generally looking at an iron panel, looking at hemoglobin are going to be really important as well to reflect an overall picture. And sometimes in ESR, CRP to make sure that we're not seeing an acute phase reactant response is important as well, as ferritin will go up when folks are ill. Goal ferritin generally for these endurance athletes is going to be greater than 50. Someone who's less than 20, we consider as nearly zilch in terms of their iron stores. And so that's an athlete that may be really symptomatic. Someone who's going on to major competition may be a candidate for IV iron, or someone who's just really not recovering. I would absolutely have this person see hematology and have additional workup done to figure out why this is happening before we're doing repeat IV iron infusions. But that may potentially be necessary for a short period of time, depending on what's going on. Pretty rare that we're doing these IV iron infusions in general. Anyone who's between 20 and 50, we're generally starting some routine oral iron supplementation as long as they tolerate it okay. But ultimately, my goal is to get them off of it and get their nutrition to catch up. We know folks who are lower in ferritin are generally also going to have some component of low energy availability. So if we can address the entire diet and make sure they're getting enough nutrition, oftentimes they'll be able to maintain increased levels of iron, or at least be able to reduce some of the volume of supplementation. We have to work around hepcidin with this. So hepcidin is released anytime we have an iron load, as well as after high impact or high intensity activity, and generally it's lowest in the morning. So the way we recommend these athletes take their iron supplements, such as ferrous sulfate, is either taking it fasting first thing in the morning, potentially with a couple ounces of orange juice for that acidic environment for absorption, and trying to avoid that 3 to 6 hour time frame after an intense workout. Ultimately, if an athlete can't do that, I just want them to get the iron in, but as much as we can try to cater to those hepcidin patterns, it can be helpful for absorption. If athletes are going altitude training, they've got to have their iron stores up, and we want to make sure that happens a couple of months prior to them transitioning to altitude training. I want to put a plug in for this concept that came out with one of the most recent REDS consensus papers that low carbohydrate availability exaggerates hepcidin release. So, someone who has a low calorie diet, so insufficient energy intake, they're going to have increased levels of hepcidin, which is going to block their iron absorption. But someone who also has a low carbohydrate diet, that's actually going to make it a whole lot worse. Someone who has a normal calorie diet, but then also relative carbohydrate deficiency, we actually see hepcidin levels increase as well. So sometimes, we talked about some of the nuances of diet. Sometimes it's that their within day energy balance isn't there. Sometimes it's low carbohydrates. And I still see athletes who are worried about gaining weight by consuming carbohydrates, even though they're in an endurance sport where they need those readily available carbs. So I frequently will ask when potentially asking for general day in a diet and get an idea of what types of foods they're consuming together. Um, it's not perfect in terms of nutrition diary, but certainly I've had a couple athletes who they just completely left carbs out of that picture as they were going through the things they ate that day, and that made it pretty darn clear of what we needed to work on. Vitamin D, also a big hot topic. We know that low vitamin D is associated with some levels of poor performance, and this is getting more and more attention from the research side. Super easy to address, and I've been surprised the number of adolescent male athletes coming in with tibial stress fractures that had low vitamin D and kind of surprised me. So I've actually been more apt to at least supplement and or potentially check their levels to see if this is potentially why they had their injury to begin with. So vitamin D levels greater than 40 are generally our goal. Greater than 30 is considered adequate, but I try to give folks a little bit of a buffer and give them a little bit more supplementation if they're just between 30 and 40. Below 20 is deficient, and certainly you could do a prescription dose to boost their vitamin D level. That's that 50,000 I use weekly. But generally, I'm doing something between 2 and 5,000 daily for these athletes, depending on how low they are. I do like to check these. Again, if I can get folks off supplements, I like to, but I'm a little bit less worried about the vitamin D than I am the iron. Dietary calcium intake should be somewhere between 1,000 and 1,300, depending on male, female, perimenopausal, postmenopausal, lactating. But ultimately, they should be getting at least 1,000 milligrams. I'd love for that to all be nutritional intake as opposed to supplements. But if we need to supplement, we certainly can, especially in someone who may be recovering from a bone stress injury. So I like to put another plug for stress. So we talked a little bit about life stressors being important. If someone's spending a lot of energy running around after kids, if they're not sleeping because they're up all night with a new baby, all those types of things are really important. And so one of the physical therapists I work very closely with, Dr. Kate Mahivic Edwards, she talks about this idea of a bucket of stress, and stress is stress. So stress is stress means any stressor, your body does not necessarily perceive a difference. So if it's physical stress, psychological stress, a grief response, those all go into the same bucket. And your body essentially has only so much capacity. So as that bucket fills up with stress, if it's overloaded, we're going to start having consequences. So, if someone's not sleeping, they had a loss in their life, major transitions causing stress, and they're intensely training, then their bucket may overflow. And that could be one of the things that potentially contributes to them having an injury as well. So, simply asking about stress levels, if they're sleeping, if anything's changed, is really important as well. And thinking about these athletes as whole body, comprehensive, and holistic care. So, coming back to the case that I introduced earlier and plugging in some of the nutritional components here, this athlete said, "Well, I eat plenty. He eats collegiate diet, he's on campus, feels like he's getting enough. But ultimately, we get some labs, and some labs are kind of borderline low. They're not extreme, but they're certainly enough that they give me pause. And I do my very best to get this person in with the dietitian and successful in this case. This athlete had a total T3 of 100, which is just getting into that lower quartile for this particular lab work, which makes him not abnormal, but certainly in a stage that I may be worried about low energy availability. So we have conversations. We want to avoid within day energy deficits, not skipping meals and snacks, having things with him in case he's not able to get somewhere to get food. doing pre and post workout nutrition, not running on an empty stomach first thing in the morning, but having some kind of carb load as he's going to his workout. And then making sure he's adding in those carbs before that morning workout. Whatever it takes for his GI system to tolerate it. Sometimes there's some gut training that goes along with it. Sometimes it's also just finding something that's palatable in the morning for this athlete. Hemoglobin is normal. Ferritin was technically normal, but below our goal for an endurance athlete of 50. So again, 45, I still kind of pay attention to it and I talk to the athlete about it. They're going to say, I didn't see any red numbers on my labs. So I thought everything is normal. And I'm going to say, well, hold on a second. Let's still kind of dive into this. So I probably would not supplement this athlete if they were out of season, not competing. But for someone who's in the middle of a cross country season, I definitely would give them a little something and then would again use this as impetus to get them in with a sports dietitian to get a little bit more education and counseling. Vitamin D, again, normal on labs is not going to show up red, but I like it to be more like 40. So give them a little bit of vitamin D supplementation, kind of higher end of a maintenance dose from my perspective. And again, all these things, the total T3, ferritin, and vitamin D all point toward at least some level of borderline low energy availability. And I like having these numbers as well because they can make a suggestion too that I can use an objective number to help convince that the nutrition piece is important for him. So, anytime we're talking about these athletes and we're talking about the concern for problematic low energy availability, we want to have some kind of systematic way for going through this, especially if we run into resistance and we need to be able to have some objectivity as well. So, especially in the collegiate setting, professional setting, I love being able to use some of these tools to stratify. And then be able to help educate the patient as to why you're concerned instead of having it be much more of an abstract concept. So, we have two tools. We've got the relative energy deficiency in sport clinical assessment tool or CAT2. We also have a similar tool from the triad as well. Both of them, I think, give us a great idea of where we need to go, and there's some overlapping characteristics with it as well. There's also the screening process that's outlined on the top of the screen here. So having a better idea of how we go through a large volume screen to figure out who we need to look at more closely, and then what are some red flags that suggest this athlete needs more workup and closer follow-up. On the bottom, we have our traffic light system. So we've got green to red. Green means the athlete is very low risk and we don't need to restrict them, don't necessarily need additional follow-up or attention. Anyone getting into the yellow-orange category, we should be following and monitoring, have a low threshold to potentially discuss whether or not they need to modify activity or we need to get other folks on board, like a dietitian, for example. And then someone in the red category may be severely modified, hospitalized, restricted from activity. Basically, we're looking at clinical criteria with this. So there are primary and secondary indicators, which I'm not going to go through for sake of time. But I think all of these are super important. A couple of the things that we went through on this particular case, the total T3, for example, is one of the indicators. And basically, when I put everything in to calculate his risk level, it put him in a yellow. Majority of our endurance athletes generally end up being in a yellow to orange category. And so sometimes it can be a little bit challenging to figure out which ones really need that additional attention. And if folks have had, bone stress injury in the last couple of years, that will bump them up and put them in a higher risk category. So, um, but this does give us good impetus and objective information if we need to potentially pull someone from sport. So looking into biomechanics, when I have an athlete come in, we're doing a focus exam on the body part that's painful, but then I'm also doing a pretty extensive evaluation. Like I mentioned before, that single leg squat's really helpful to look at their mechanics. If we think about running as a bunch of dynamic single leg squats, we can get a little bit of an idea of what they might look like when they're running and what's happening at their pelvis, knee, and foot. We want to look at some activation patterns as well. So can they contract their glutes and the necessary patterns? When we look at lower extremity tendinopathies, there are a number of different patterns that have been associated with tendinopathies. So not necessarily specifically in runners, but we do know a lot of these patterns also hold for bone stress injuries as well, which we'll talk about in the next slides. But looking at things like increased peak rear foot eversion, increased peak knee internal rotation, knee extension at heel strike, increased peak hip adduction, increased lateral trunk flexion, which is essentially that like compensated Trendelenburg appearance, tight tight ankle plantar flexors, so not being able to dorsiflex well, weak hip abductors, and ultimately, if we look at this picture on the right side, this is what we're looking for, is that contralateral pelvic drop, the internal rotation at the hip, the genu valgus. If this athlete did not have shoes on, we might see overpronation through the foot as well. And some of these things can give us an idea of what they might look like when they're running and some of the risk factors for injuries, whether tendinopathies, as here, or looking at bone stress injuries, which again, you'll see this looks very familiar. Excessive hip adduction, knee internal rotation, subtalar pronation, hindfoot eversion, and then heel strike. And heel strike, I say with a caveat because we don't need everyone to stop heel striking, but we do need to minimize some of the forces with it. So we may be trying to prevent someone from having excessive dorsiflexion when they're landing on their heel, having an extended knee, overstriding, heavy landings. All those things are going to increase the effects of that heel strike. And so we want to try to minimize that as well. And then a couple studies that look specifically at biomechanical risk factors for running related injuries. Again, higher impact loading variables, greater peak contralateral pelvic drop and trunk forward lean, and then extended knee and dorsiflexed ankle. So a lot of similar patterns that we're seeing with each of these, but some of these things with evidence behind them in terms of running related injuries. So when we see this contralateral pelvic drop, this is what we're looking at. So that left side of the pelvis is dropping, and I'm going to exaggerate things a little bit with the markers that I draw in here. But as you can see, as that contralateral pelvis drops in stance, we also see right lateral flexion through the spine. Yes, exaggerated just a little bit, but the idea suggesting that we're going to end up potentially having back pain. So you might ask this athlete if they have back pain, for example, but being able to address multiple components is really important. Understanding that pelvic drop is not just glute weakness, but now we're also having back consequences as well. And posterior chain might be tight from neural tension now. So, certainly a cascade of concerns that can happen. Again, reminder do that single leg squat in the office. Get their shoes off when you do it as well, because you can have the same picture that you may see that when you get them on the treadmill as well and start being able to predict what they look like when they're running. And then an extended knee and dorsiflexed ankle at initial contact. So here's two different pictures, someone running at a pretty quick pace. This is our case. And then on the right side, someone running at a slower cadence in some of the patterns of a master's runner. And both scenarios, they are overstriding. That knee is extended a little bit less so on the right side. And those toes are straight up in the air. So quite a few things that we can do simply with that component to reduce some of their risk factors for injury. Looking at biomechanical risk factors specifically for bone stress injuries, again, broken record, a lot of similar patterns. And then we also see things like low step rate, longer stride length. These can go along with someone who might be overstriding as well. So a lot of similar patterns, but different things that we may look at. So we can certainly calculate a cadence quite easily when someone's on a treadmill to be able to identify if that's a concern. And then higher plantar pressures, which that's looking at a force plate treadmill. And then another trick to be able to find out if someone, what someone's pattern might look like without having them on a treadmill is getting a pair of shoes. They're somewhere in that moderate range of wear, not brand new, not totally worn out. A normal shoe wear pattern would look like someone who's got some wear on that lateral heel and then more central for their forefoot with push off. If they're wearing more medially, you may be looking at someone who's a severe overpronator, wearing more laterally, someone who's supinating more. So some level of either excess motion or restricted motion, but ultimately we want folks pronating. We simply need them pronating at an appropriate rate. So not a rapid pronation, not too much pronation, and they need to be able to come back to neutral to push off from a rigid lever arm. If they're pushing off in pronation, they're pushing off on a very flexible foot. That's also not going to be energy efficient and put them at risk for injury as well. Just a reminder, when we're looking at run gait, we're looking at a double float that distinguishes running from walking. But then we're also looking at things like increased speed, increased forces that are associated, and increased demand for neuromuscular control. So it's not quite as simple as we have a float phase when we're switching from walking to running. There's a lot more demand on the body as a result, and the neuromuscular control piece cannot be underestimated. So why do we do run gait evaluations? Injury prevention is a big one, and I love when we can do it from a primary prevention standpoint. Although you can certainly argue that we want to be cautious changing someone's form when they haven't experienced injury and they've been having a long run of success with their running. Certainly, from a secondary standpoint, I'm waiting for an athlete who's injured to be pain free and progressing back into running. Generally, I want them running 15-20 minutes comfortably before we get them on the treadmill. And then we're able to take a look at, are there any asymmetries? Are there any extremes in terms of their motion? Do they have excessive motion that's not benefiting them and moving forward and improving their running economy? Might also tell us if they're ready for advancing their training. If they still have a huge pelvic drop, maybe we don't want to increase their volume and we want to keep them doing some cross training before we're starting to progress them. We want to make sure that PT is kicking in and doing the trick. And then longevity of running careers. So someone who is minimizing forces through their joints and their tendons is going to be much more likely to continue to be running uninjured and for longer periods of time. When we improve running economy, we do things like minimize active muscle mass, aligning legs with the net force vector, and then maximizing the effects of elastic recoil. So essentially, we're trying to prevent any of those extremes of motion. And then looking at run gait in the office, many ways that you can do this. You can do this with a million cameras. You can eyeball things. The way I like to do this is at least getting video in two planes, so posterior and lateral, potentially getting a shoe close up to be able to visualize their shoe motion a little bit better or their foot motion. Being able to slow to quarter speed or be able to jump from picture to picture to see what's going on in each phase of the cycle. Being able to listen. So I'll listen real time, but sometimes I'll also have the athlete listen when we're looking back at the video as well, looking for asymmetries or heavy landings. Recognizing there are some limitations with this. This isn't something that we're going to be telling someone they need to run a very specific way, but oftentimes it can really help get buy-in from the athlete and then also potentially bring out some dynamic things that need to be addressed that weren't inherently obvious when they were on the table. We may look at things like cadence. So generally we look at 160 to 180 steps per minute as our goal, but it's going to be different for everyone. We look at a base width. Generally, folks are going to be too narrow as opposed to too wide. Sometimes I'll see one foot that steps wide for one reason or another as well. Foot strike, are they heel, mid, forefoot? What's their foot motion like? Again, if they're pronating, how much, how rapidly? Are they coming back to a neutral position before push off? What's their vertical displacement like? Is this a bounding basketball player or are they efficiently moving forward? Do they have sufficient hip extension? And then, really importantly, are they stacking their chest and pelvis so that they can do proper diaphragmatic breathing and activate their deep core? That can be a really big component as well that can contribute to injury. And then, looking at trunk lean, arm swing, I like to talk about heart to pocket arm swing. If they're crossing over, sometimes the arms can give up more information as to what's happening down below and their overall stability. So sometimes I tell athletes I'm not super concerned about their arm swing. We can certainly make them more efficient if we improve it, but oftentimes it's a secret to telling us what else is going on in the chain. So this athlete, there were a few things that we saw, and he actually did fantastic with physical therapy. Ended up being an All-American after this. He had some poor lumbopelvic mechanics. Deep core wasn't active, glutes weren't active, intrinsic foot muscles. And so working on a lot of pelvic stability, working on his deep core, and working on the neuromuscular control in his feet. He had a quad dominant gait, overstriding, reduced hip extension, and then a flattened lumbar spine. And so addressing some of that potentially with cueing, but oftentimes a lot of those things will fall in place as he's working on the lumbopelvic mechanics. And then looking at some of the high loading rates. So his overstriding, low cadence, heavy landings, which we can cue soft landings. There's been some evidence behind that being effective. And then that increased vertical displacement is going to improve again as we're addressing these other concerns. So I'm going to give a very quick plug on training errors. There's certainly lots of information out there and evidence, but just from a clinical standpoint, I think it's good to do a little bit of a screen. So asking folks how many days a week they're training, how are they increasing their volume, how many intense days they have, are they spending most of their time at conversational pace when they're working out, are they mixing cross training in, are they strength training? So just getting a general idea of what's going on. Sometimes things really stand out that are going wrong. And so you don't necessarily have to be an absolute expert from the training standpoint, but just being able to look at some of those patterns, even a change. So I never strength trained before. Now I'm doing 3 days of strength training on top of my marathon training. Those changes and big volume changes or intensity changes can certainly pique up your interest and give you an idea of what may be going on. So ask those questions, even if you're not super confident in exactly how you may be able to adjust their training. And generally, that's going to be done in conjunction with their coach in any case. I will give them relative activity modification guidelines. These were developed by Dr. Wilder, and I've used them ever since. So, making sure their pain isn't more than a 3 out of 10, they're not limping when they're active, and that their soreness isn't lasting more than 24 hours. Certainly, a bone stress injury is going to be a bit of a different story, but if we're talking about a soft tissue injury that they're safe to continue through, or an osteoarthritis scenario, this is a pretty reasonable activity modification considerations to give to someone. Cross training can be valuable, accessory work, strength training, as I mentioned. And then this 10% rule of increasing volume each week, it's been debunked to some extent, but I think it can give a general idea of how we should be increasing volume, especially once folks are in kind of that moderate volume category, and certainly can keep folks safer if they've been increasing faster than this. Someone who's more experienced might be able to increase volume faster. And then we also want to consider, are they increasing volume and intensity? Are they changing to hill workouts? So we want to change just one thing at a time so that we have only one variable that we're adapting to and allowing the body to catch up. I generally recommend 1 day off of organized activity per week. Don't think we necessarily have the data to support that, but anecdotally, anytime I've had an athlete who's gone to taking 0 days off or they're cross training on their day off, we generally end up running into trouble. And one of the ways I explain it to athletes is that we are just not perfect recovery machines. We get stressors we don't expect during the week. We have a bad night of sleep. And so if we have that extra day that's completely off, that's kind of our buffer to be able to catch up on some of those areas where we didn't do the best of jobs in terms of recovery. So that is generally my recommendation. And I don't mind if they go for a stroll with their friends or do a little bit of mobility work, but really keeping this um, low intensity and even giving the brain a break. I think the psychological component's important too. So two things I mentioned to this athlete, he was injured and he was running 75 miles per week. And not to say he can't sustain that in the future with all these biomechanical changes, but we make a mental note. Hey, this at one point was a threshold. We went over 75 miles per week and now we got into trouble. If we're improving nutrition, we're improving biomechanics, maybe that is sustainable at some point, but just simply making that mental note. And then he was doing pull or bike on his quote unquote rest days. So he was cross training and not taking a full day off. And so we encouraged him to take that full day off to improve his recovery. And ultimately, most of these conversations are looking at holding these athletes back and giving them more recovery than they realize they need. And that's oftentimes when they can really improve. So again, coming back to this visit plan, there is so much that we're covering. These are multiple visits. These are multiple providers. I oftentimes have a physical therapist, dietitian who are having many of these same conversations, and having that person in your boat and in your community, your regular conversation is so helpful so that you're giving them very similar messages each time each of you are talking to them. So, key points. Overuse injuries are multifactorial. If you get nothing else from this conversation, there are just so many things that you need to look into and not write off. And you need to have at least something that seems like there's a really good reason as to why this happened. And if you're not finding that, then you may need to look a little bit harder because you don't want to send that athlete back out into the same environment and they get injured again. Injury care involves secondary injury prevention, and this ultimately is going to help optimize their healing and potentially help expedite it as well. So, as you're working on nutrition to get them back to running, you're also improving their nutrition while they're trying to heal from an injury. And so, those things are going to be helpful as well. Identify risk factors, make sure we address them. So, what I call the three pillars: training, biomechanics, and nutrition, and make sure you're asking questions about them. Make sure you're revisiting. Maybe you're asking questions, the same questions in a different way to see if they get a different answer. And so there's just so much to be gained from that, and having multiple touch points can be really valuable. I'll generally follow up with athletes every 2 to 3 weeks during a stress injury cycle, even if they're non-weight bearing for that full 6 weeks. That gives us touch points. We get to find out how was their visit with the dietitian? Are they tolerating their iron supplement? Do they have additional questions? And really working on that educational piece, I think, is so valuable. And then, of course, I can't talk enough about the interdisciplinary care team. So even if you don't have a multidisciplinary clinic, which there aren't too many of them, being able to have those folks in the community that you can turn to, and that warm transfers is so valuable. And me being able to tell someone that this is the person I recommend. Is it okay if I give them information about your case? And sometimes even have them reach out to help them schedule and encourage them to be able to see that person. And I think those medical relationships are very appreciated by patients. So thank you for time. I know I went just a little bit over here. I want to put a quick plug at the bottom here. So the podcast series, Interdisciplinary Case Miles. This is myself, Dr. Kate Mahivik Edwards, physical therapist, and Kelsey Ponte is a sports dietitian. We have a conversation about cases and some of the nuances of treating runners. And then the running medicine textbook by Dr. Wilder is also another great source if you're looking for more light reading on running medicine. So thank you for your attention and take any questions.
Thank you, Dr. Reiser. This was such an amazing talk. And then, we only had about 50 minutes, and then I'm sure you can talk more about the running medicine, but terrific, terrific. So one question we have, or one of the questions that we have is one, would you mind sharing the slides to folks? If so, we could probably ask Andy to basically send it through using
Oh,
PDF.
oh,
If not,
yeah.
yeah, yeah.
Yeah, I would, no problem.
All right, perfect. The other question I have right now is, do you use a questionnaire to help streamline your HPI or the clinical visit? If so, is it helpful with getting those like answers to the sensitive questions that you brought up?
Yeah, so I've tried a few different things. I've tried a comprehensive questionnaire. I think there are some challenges because you need to either get it to them ahead of time and identify that they're a runner. You need to ask those questions too. I think sometimes athletes feel like it's too much and unnecessary, and sometimes it's challenging to be able to get through all the information to review to get to the patient. And then also you got to make sure you review all of it because you've got this data and it's going in their chart, and you've got to make sure you go through it. So I've gone back and forth. I have done some questionnaires, but a lot of times, I have kind of a standard series of questions that I ask and have conversation about. Because sometimes, when you ask a question and on a piece of paper, yes or no is circled, and then you ask the question, they're like, well, no. It gives you a chance to say, well, tell me more about that, right? So I think having that conversation is really valuable. And some of the sensitive questions, I get a lot more information, I think, when I'm asking them verbally and kind of prefacing them with this is why I'm concerned. So I think ultimately you need some level of standardization so that you don't miss important points. But I also like to be able to spread out some of the sensitive questions that are diving a little bit more into the weeds. That way, as I develop rapport, then we can start talking more about some of those questions too. So that's a long answer to say absolutely questionnaires are great. Having a streamlined, standardized set of questions that you are using to outline your talk with the patient is valuable. So you're not missing anything as well, especially when I was early on, that was really important. But I also think there's so much nuance and value in developing that rapport that can just be so challenging. Nutrition is a very personal and sensitive topic. And it's something that you can potentially lose patients if you suggest that you know exactly what they should eat, and they feel like they've been putting a lot of work into it. So um, it it's tough, and I think there's a lot of art to it. But yes, you don't want to forget anything.
Makes sense. I guess one question I had is, how would you differentiate between overtraining syndrome and then red S? I know there are a lot of overlap symptoms, but you don't kind of misdiagnose one over the other as well because the treatment is very different. So how would you kind of go about that?
Yeah, I mean, I think the general idea is overtraining is maybe there's more in terms of the exercise excess side, and the relative energy deficiency or low energy availability is more deficiency on the energy intake side. But obviously, there's combinations of both on both ends of the spectrum. At some point, our bodies can only absorb so much and recover so much. And so I think from the overtraining side, you could be getting enough nutrition, but if your recovery just stinks, you're going to be overtraining, or you're rapidly advancing your activity too quickly. So I think that's where really asking a lot of these questions and looking at patterns can be so valuable. And I ask a lot of nutrition questions, but I also understand that when I ask generally what someone eats in a day, I don't have volumes and times and those types of things. And dietitian's going to dive into that information a lot more. And so I depend on them to give me information. And if I talk to the dietitian, they say their nutrition looks great. Well, then we're looking at some other things. Is there a medical problem going on? Do we need to look more closely at the training piece of it for the overtraining syndrome? Or is this even psychological? Have they been grinding for years and they're just tired and burned out? So potentially addressing the psychological side as well, which I'd like to have psychology involved more. It's just sometimes convincing someone they need to pay for yet another provider can be challenging. So kind of picking your battles, I think, can be valuable. In a perfect world, I have them all see psychologists as well. It's a good question.
Makes sense. We have two more questions. We only have about a minute or so, but one of the question is, do you have any recommendations for counseling patients in return to run programs when coming back from overuse injuries, especially bone stress injuries when they have been off running for an extended period of time?
So I have a few different methods. Dr. Wilder has his own method. So if you've ever watched any of his lectures, I encourage you to, if you haven't, take a look at his running medicine tech books, and he goes through some things as well. And fellowship, the programming that I would do is a walking program that progressed to walk jog and then progressing to continuous runs from there. More slowly, depending on how much time they had off, if they were non-weight bearing for a period of time, if they had delayed healing, if we have REDS concerns. So a lot of things that go into the mix there. I also have some physical therapists who are very talented at this, and oftentimes I will simply kick it to them and have them start the return to run and then progress it in conjunction with the coach and give some guidance. So that can be one of the best ways to do that. I do also have a couple physical therapists who will start with pogo hops and progress them into running that way, which I also like as well. Again, it puts you in a position where if you have gone too far and they're sore, you haven't overdone it wildly. You've made them a little bit sore and you back off a little bit and then progress so it doesn't really set you back. So many ways that you can do it. There's quite a lot of literature. And if you take a look in PubMed, there's actually a few where they have things written out and like criteria to go to the next step. So many ways to do it. There's also using an Ultra G or anti-gravity treadmill. You can progress them like immediately on the treadmill because you can reduce their body weight. And so sometimes that's really good from the mental health perspective that someone can do something that feels a lot more like running. Aqua jogging is another cross training activity that Dr. Wilder really vouches for as well, because again, it's mimicking running, but it's low impact. So there are just numerous ways to do it. And sometimes, depending on what my resources are, depending on what the athlete has access to, and then also what's going to fit them the best from the psychological standpoint as well.
Great. One last question. So how you kind of touch base on it, but how do you make sure your patients are getting quality, like a good quality PT with therapists knowledgeable about gait analysis or running specific considerations? And then also, do you have patients routinely work with non-medical coaches in terms of like running?
Yeah, so I talk to PTs. I talk to them, I read their notes, I ask the patients how they're doing, I ask the patients what they're doing, I have them show me the exercises to make sure they're doing correctly. I have them do the single leg squats when they come back in. I retest their activation patterns. And over time, especially, where I am now in Charlottesville, I mean, we're a small community, so I know most of the folks. And over time, you figure out who has a knack for this and also really enjoys it, who wants to do the physical therapy return. And generally, those relationships develop. A couple times I found someone that I thought did a fantastic job with a runner, and I took them out to coffee and I, picked their brain and got an idea of how they like to do their programming. So, it takes time, and it's hard to do in a bigger environment. But once you find those couple of folks, I use them, and everyone has different ways that they like to go about it. I almost always will send a patient out with a few names. Like, these are folks that I think are going to fit your injury pattern as well as um, uh, you know, meld well with your psychological state and kind of what would be helpful for you. So I do my very best to try to match them up as I can. Boy, PT is in demand these days, so it can be really tough getting folks in. Same thing with the physician offices. So it's challenging and it takes time, unfortunately, and that's unpaid time. But I think there's so much value in being able to get bang for your buck. And frequently, I have patients come in who saw run-of-the-mill therapists who didn't feel comfortable with runners or run gait, and then we're going back to the drawing board and getting them in with someone else. So I've got to convince them that another round of PT is worth their time. Yeah.
Great. So thank you again, Dr. Reiser, and we're going to pass time, but thank you for a great lecture, and then thank you everyone for joining us, and we'll see you guys in a couple weeks. Thanks.
Thank you. Have a good night.